Oh, sorry, I need your phone number.
We're live on YouTube now, Chair.
Okay, thank you. Good afternoon, everyone, and welcome to the June meeting of the Adult Social Care and Services Scrutiny Panel. And we'll go straight on to the agenda. Have there any apologies for absence?
We have, Chair. We've had apologies received from Councillors Higgins, Jones and Walker.
Thank you. Item number 2, any declarations of interest? See no hands. We'll go on to item 3. And there's some minutes of the Adult Social Care Service Scrutiny Panel of the 30th of March. Can we all agree those minutes are correct?
Agree, Chair.
Graham, we've got a seconder. Thank you, Dorothy. Item 4. Director of Adult Social Care and Health Integration will provide the panel with a verbal update regarding the integration of health and social care. So welcome, Eric Scully, and over to you, Eric.
Thank you, Chair. I suppose the key thing that I would update on is that we are moving relentlessly towards the switching on of the integrated care system arrangements, the transition from clinical commissioning groups to the ICS, which is due to take place on the 1st of July. So it really is imminent now. We are in a position now where the Chief Operating Officer, Sam Allen, is in place, is formally in place now. And the senior appointments have been made to that integrated care system. We're now also in a position that we understand the key structures that will sit beneath that. So if you'll indulge me, where I've spoken before about the integrated care system having at its head an integrated care board, which will be the formal NHS board where financial authority and the financial allocations for the region where those sit. And then underneath that, there is something called the Integrated Care Partnership. Now, membership of the Integrated Care Board at the highest level is closely sort of stipulated in the legislation that goes along with it. But then at that Integrated Care Partnership level underneath, that's where the various partners, depending on the nature of the individual area, will come together to share their priorities and their commissioning aspirations, and that will be fed into the Integrated Care Board for its deliberation around decision making. The key for us, as has been obvious all along, is that we have for our integrated care system a geography that's larger than anyone else's. Might not have a larger population, but we've got the North East and North Cumbria integrated care system. So it runs, you know, to the north of Cumbria and the northwest, down to us and Redcar and Cleveland in the southeast. So it's an enormous geography. And if I had been a betting man, which I'm not, before we embarked on this journey, if I'd had to kind of cut up the area and arrive at what I thought was, from my perspective, the kind of the logical geographies for an integrated care system, I would have come up with 4. 3 up the east coast and 1 over in the northwest coast. So Liam Donaldson, the former Chief Medical Officer, is the chair of the Integrated Care Board. And actually the representations had been made to Sir Liam Donaldson throughout this development exercise that really a single integrated care partnership, you know, bringing together all the relevant partners across that enormous geography, was simply not going to be practical. And it would mean that individual places would have tiny voices and we'd have casts of thousands around the table. So where the NHS has arrived at formally now is that we will have sub-ICPs. So just recapping, integrated care board at the top level, then an integrated care partnership, which is basically deals with the kind of the commissioning ambitions and the pressures and the like. And that will be fed by 4 sub-ICPs. And that's when it gets down to what I feel is the kind of the natural and the clear geography. So we will have a sub-integrated care partnership that will be on Tees. And it will be made up of the 5 local authorities that sit around the Tees Valley. And basically it'll be the same footprint by and large as the Tees Valley Clinical Commissioning Group at the minute. So I will find myself, after the ICS switches on, I imagine having largely the same conversations with the directors and chief officers at the Clinical Commissioning Group and in my partner local authorities as I have at the minute. I do not expect that in the practical day-to-day operation, much will feel like it's significantly changed. I still also feel that there will be benefits that will come from this, particularly in terms of the way in which, and I've said this a number of times now, that the prevention agenda and the longer term qualities agenda, the way that it is more rigidly wired into the system than it was previously. So each local authority area, we were asked to look at 10 operational priorities, 10 things that we are wrestling with, you know, within children's services and within adult services, within public health. And there is a meeting in Gateshead on Friday of this week where teams of senior officers from all of the involved local authorities will meet together to have a conversation about how we start to knit together the priorities that we identify locally into a set of themes for the ICB. So I think Friday will probably be a key day for us in that we will get a sense of how we start to knit together that enormous group that is the ICS. The priorities that we've identified locally, none of those will be a surprise to you. The priorities around children's services, I don't have those sat in front of me at the minute, but there will be the same priorities that you will recognise from the work that's going on within Middlesbrough's children's improvement journey and the challenges we face within education. Within the realms of adults, the 5 themes that we are working on are to do with, one is to do with ageing well, one is to do with sustainability, which is the workforce challenge in large part. One is to do with hospital discharge and admission avoidance, which is all familiar to us. One is to do with mental health, which remains an ongoing high priority, well, pre-COVID, but it remains probably more of a challenge post-COVID. And finally, one about prevention and inequalities. And those 5 themes you will start to hear us locally talk about, I think, more on an interagency level, because those are the themes that have emerged out of work we've done with the CCG, with colleagues in the VCS, with public health, and we're working closely with Redcar along those lines. So I think the requirement for us to produce local priorities to feed into the ICS will help to galvanise some of that joint working locally as well. So I've talked for a little while. I'll probably stop there, but that's the kind of the key changes since we've last spoken, I think.
That's great, big changes. And before we go ahead, does anyone want to ask, by the way, Geraldine, welcome aboard. Anyone want any questions for Eric before we move on? Denise, go ahead.
Yeah, thanks, Chair. Thanks for that, Eric. Yeah, it is kind of a reflection on the information that you've already given to us before. How's the transition going then from the one system to the other? Do you envisage any hiccups or problems, or do you think it'll go through quite smoothly?
So at the minute, the senior officers within the integrated care system have been appointed, and that includes the sort of the accountable officers for the various geographies. So the accountable officer for the area that we sit within. So what they've had to do is create the structure at the high level, but they've also created sort of local offices, if you like. These are the local kind of accountable areas that will work with local authorities around local geography. Keep saying the word local. And Dave Gallagher, the Chief Operating Officer of the local clinical commissioning group, will be the accountable officer for our local geography. Not all of the final appointments have been made, but I think they will all be made, the senior appointments, except for the local staff, within probably about the next 2 weeks or thereabouts. And I'm expecting I'll be talking to the same individuals as I've been talking to for the last few years. In terms of financial flows, I think there is an obvious commitment that there is an allocation to the lowest practical level of the maximum possible resource. And that sounds like management speak, I get. But there is an operating model that has been circulated to us that, John Sampson, the chief executive from Redcar, has been the kind of representative of the Tees Valley chief executives in these discussions. And they've looked at the level at which delegation will sit for different sorts of financial decisions. And broadly speaking, it feels to me that it's sensible and it works in line with what we need to get kind of local sort of control or determination of what's important to do in Tees Valley. I think that there is a potential for us to get into a little bit of pushing and pulling about what happens when we get to the point where the question is raised, can we do some of these things more efficiently if we do it once across the whole geography? You know, so for instance, continuing healthcare, that determination about whether or not the NHS or the local authority pays for some aspects of an individual's care. We can see that across the integrated care system, we do that in slightly different ways in some places. Now, it does make sense to try and rationalise that, to have an efficient way of work, a consistent way across the piece. That makes sense from the NHS perspective. I think from the local authority perspective, I can see that there are some areas that do it in a particular way that I don't think is the appropriate way for us to do it. So we might get into some of those discussions where we test just how much sovereignty we have on a local basis. We haven't encountered any of those issues yet. And if we do bump into any of those issues, and those will be the sort of things that will cause us problems about the kind of the move into implementation. We haven't hit any of them yet, and we might not hit them. I'm not, if I'm honest, I'm not terribly worried about it. I think we do have sufficient clout for us to find a way through that. So there are many things that are causing me more concern at the minute than the transition into the integrated care system, which I think has quite a lot of opportunity about it.
Yeah, thank you. Thanks, Eric.
Yeah, thanks, Eric. Anyone else, any questions for Eric? Can't see any hands. Thank you for that, Eric. We'll move on then.
Welcome, Chair.
Item number 5 is the adult social care and overview. Eric is in attendance, obviously, to provide the panel with an overview of the main service areas within his remit and an outline of priorities, key issues, and challenges for the year ahead. This may also help members in formulating the work programme for this year, which is the next item on the agenda. Therefore, if there are any areas of interest or matters that arise from Eric's report, please bear the work programme in mind. And now I'll hand over to you again, Eric.
I'm going to try and be unusually. Actually, Chris, could you bump it up to the previous slide, please? I'm going to try and be unusually brief on this because I know that most members of the panel have sat through these sort of overviews before. So the Directorate that I have the privilege, and it is a privilege of being Director of, I think of it in sort of 4 blocks. And some of this is in a bit of a state of flux at the minute. We're making some changes, but bear with me because this is how it lodges in my head, and I hope it's helpful that way. So the two at the bottom, public protection and public health, I mean, those broadly speaking work into different scrutiny committees, although most of their activity is in the portfolio of Councillor Coop as the lead member. So public health, most of the discussions that go on around their delivery sits within health scrutiny purview, I think. But there may be elements that we want to bring in over the course of the year into social care scrutiny, because there is a bit of a blurring of the lines about how we work alongside public health. And then public protection, it usually sits outside of this scrutiny as well, albeit it's within Councillor Coop's portfolio, with the exception of the selective landlord licensing component that sits with Councillor Planham. So it's a slightly more confused, or not confused, but complicated picture than it was last year. So the bits that I think that we focus on from an adult social care perspective are those 2 subsections. So the first one I think of as the social worker, the field work teams, the kind of operational teams that broadly speaking do the initial contact with individuals, the assessment of need, the support planning that goes on in terms of working how we will establishing how we will work with those individuals, and then the care management that operates alongside that. I haven't listed all of the teams because it just would turn into a bit of a list, but these are sort of the key themes that sit within there. So our access team is the front door. That's the point at which new referrals come into our directorate, come into the council. The safeguarding team, it's pretty much self-explanatory, but that's the team that conducts safeguarding investigations for us and puts in place the plans around that. We have a number of mental health teams, and each mental health team has a slightly different focus. So we will have a psychosis team, we have an affective disorder team, we have an older person's mental health team that deals not exclusively but predominantly with individuals with some form of cognitive impairment related to their age, or related to dementia, I should say rather. And then we have our forensic mental health team that deals with individuals who have been in the criminal justice system, but that's been driven by their mental illness. So they work in and out of Rosebery Park Hospital primarily. We have our mainstream hospital social work team, which works primarily with James Cook University Hospital. We have 2 community social work teams who are the kind of the mainstay, the backbone of the care management work across the town. They're split into an east and west locality. We have our occupational therapy team. I appreciate they're not social workers, but they operate as a fieldwork team. And then we have our provision around domestic abuse and homelessness. And I've realised that entirely by accident, I've missed our learning disability team off here as well. They will be unhappy at me if any of you tell them that. So those are the key sort of fieldwork teams that we have working within the directorate, and that's largely been unchanged for the last few years. And then we have what we call our prevention and provider services. Our provider services used to be much more extensive, but quite a lot of what we would have done in-house through our provider services, we now commission from independent providers, but we're left with a range of provisions for a range of different reasons, really. So Levitt Court is our residential reablement facility with a small, our residential respite facility with a small so long stay residential component in there for individuals with learning disability. And we have the Orchard, which is a complicated joint day service for individuals with a significant level of learning disability and physical disability, and we work that jointly with Tees and Weir Valley, the Mental Health Trust. Our community inclusion service has a number of threads to it around the support and day services for individuals with learning disability and autism. We have the Tees Community Equipment Service, which is the equipment service that we provide on behalf of the 4 Tees authorities and the health bodies within Tees. It's a kind of partnership arrangement, but it's operated by us. And if anyone fancies a visit to Tees Community Equipment Service, it's a pretty awesome spectacle. Our Staying Put agency, which is our home improvement agency, they deal with disabled facilities grants, aids and adaptations. They're moving into digital inclusion. They're a singularly entrepreneurial team who, once again, are off to London to see whether or not they've won national awards that they've been shortlisted for. We have Connect, which is the team that responds to community alarms. We have our Handy Person scheme, which is sort of aids and adaptation scheme that you'll be properly familiar with. We have North Ormsby Day Centre, which is the last of the council run sort of mainstream, if you like, which is not to devalue what they do because it's highly specialist, but day centres for individuals either who have frailty through old age or have dementia. We have our reablement team, which is of increasing importance as time goes on. I might talk about that later. And they provide a reablement service into people in their own home, but also individuals who require residential reablement coming out of hospital, where we would place the individual within a residential care home, and then we would work with them to reable them to get them back home again. And then we have the estates team, and the estates team is the team that manages the finances of individuals who are unable to do that for themselves for a whole range of reasons. And just as I missed the learning disability team off the previous list, I have also realised, I'm having a good day today, that I've missed the deprivation of liberty safeguards team off my second list. And that's the team that works with individuals who are deprived of their liberty by virtue of the fact that they would be prevented from leaving the care establishment that they're resident in. And we are required to provide an assessment and a validation, a sign-off, that that deprivation of their liberty is in their best interest. So that's a complicated piece of work that they do. It's a very busy team. So that's the very high line canter through the spread of activity that goes on within adult social care. Obviously, our finance team, as was that used to do financial assessments, has moved into Ian Wright's Directorate with Jeanette Savage as the head of service. So that's a change since last time we met. And that was quite contentious when we made the move, but it's actually worked really well for us. And yeah, that's probably the only significant change since last time we met. I'll stop there and take any questions that might come up at this stage.
Yeah, thank you for that, Eric. Now it's for us to decide where we go for this year.
Excuse me, Chair.
Yeah.
Excuse me, Chair. Sorry, I brought two slides along. One was going to be about an overview of services, and the other one was going to be about pressures and issues. I think that the second slide, which I'll come on to in a minute, the pressures and issues, might be more useful to you in terms of deliberations around the activities of the panel. But I also note that Councillor Rooney has her hand in the air and I think has a question for me.
Go ahead, Denise.
Yeah, thanks, Eric. Just going back to one of the topics, estates, just
Yep.
for my information. Does that include things like direct payments?
No, it doesn't. I mean, the direct payments we have a high number of individuals with a direct payment in Middlesbrough. We were one of the kind of earlier authorities to embrace that. But I think if we think about the social work teams, any of the social work teams, who are working with individuals who've got some measure of need, they may well set up a direct payment for an individual so that they receive funding either to buy in their own support or some other kind of component that they may want to purchase themselves. So direct payments is a kind of normal part of the support plans that all of our social work teams will put in place. The estates team is narrower than that, and it is about individuals where the court has appointed us as the body that should take responsibility for the individual's finances. So it's a much more narrow and technical and in some respects complicated role.
Thank you.
Do you want to give us that second slide then, Eric?
Thanks, Chris. So I thought I opted not to regurgitate the sort of the established Directorate priorities and strategic plan, important as they are. I thought that from the perspective of the scrutiny position, these are the things that I think might be useful for a bit of focus this year. The transition to the ICS is a challenge for us, and it's a challenge in the sense that not that I'm particularly, as I've just said, not that I'm particularly worried about any elements of it, but it does mean that we have to bring our senior officers up to speed with the changes. It does mean that we will have to build some new relationships, albeit I think it will still be predominantly the same senior officers locally. But we do need, and I don't think this is counter to what I said before. I'm not very worried about the move towards the integrated care system. I think that there are opportunities in it. But what we need to do is make sure we are sufficiently briefed, sufficiently present, sufficiently at the table to ensure that if there are opportunities, we can take advantage of those, and to make sure that we are representing the voice of Middlesbrough Council and the Ts on the various bodies that we may well be participating in. So an example of that, will be at the moment, we are working through what will be the representation on the sub-ICP, so the kind of local committee that will receive and pull together the kind of priorities for the area. Now, at the moment, we know that chief executives from health trusts will be part of that sub-ICP. We know that there's a proposal for lead members or health and wellbeing board chairs from the respective areas to be part of that as well. But the original proposal from the ICS didn't identify directors of public health, directors of adult social services, directors of children's services being representative within that committee. So we've kind of flagged up to them that, with the greatest and most sincere respect to lead members and health and wellbeing board chairs, I think the professionally employed chief executives of health trust are steeped in the technicalities of their organisations. And I think, depending on how we see the debates, the discussions, the operation of the sub-ICPs rolling out, I think in some respects we might find it useful to ensure that DPHs, DASs, DCSs are there in addition to politicians, because I think, geeky and boring and narrow as we may be in our own little spheres, we're the people with the kind of the hard-edged technical know-how. So I think there will be issues like that kind of come along, and we will need to exert a little bit of influence to make sure that we get the kind of the best representation at the table for our respective areas. So there is a challenge in terms of, we need to have eyes on these changes this year, just to make sure that they operate as smoothly as we believe they will and can. So that's the first thing. The first thing for me, NHS reform, and really testing out if it works as well as we think it will, is something to be borne in mind this year. The real challenge for us as an adult social care directorate comes from the government's reform agenda, and that breaks down into three threads. The first one is about charging reform. Charging reform is that long-standing thorny issue about the sustainable funding of adult social care and what the role of the individual is in making a contribution to that funding. So the government have made their proposals. We have a plan in place in terms of the government have provided us with the structure that they want us to work within. And we are now in the position where local authorities are working up plans to respond to that. Now, there's a number of threads to that, as you'd imagine. Now, with our finance team moving over to our Chief Finance Officer's Directorate, the project plan around the charging reform piece has been led by Jeanette Savage. We're operating a social care reform board, which I chair, but the work stream on charging reform sits with Jeanette. And what we realise is that we will require a substantial increase in staff, because we will be required to carry out a lot more assessments than we are at the minute. And we appreciate that staffing is an issue for all local authorities. So there will be a pressure around identification of staff to undertake this. I think there also is a bit of a groundswell across some of the local authorities, particularly, it would appear to me, in the southeast, that a suggestion that government has perhaps underestimated the funding challenge around some of these changes that are being proposed. And I think that's particularly in areas where there are a high number of self-funding individuals. And now we don't fit that bill, if you like, so that dimension of the challenge may well impact on us less, but it still is a challenge for us. So there's a substantial piece of work going on about charging reform. There is also a dimension about the fair cost of care, and this is part, again, of the government's plan to put adult social care on a sustainable funding basis. One of the things that local authorities have been mandated to do is to revisit a fair cost of care exercise. Now, that is where we employ, there are a range of methodologies, I think, to do it. Government has given us a sense of what that methodology would be, but different areas are approaching it in different ways, engaging different consultants to do it for us, which is to take a deep dive into what the real cost for a provider is of providing care. So we know ourselves that fuel costs have gone up, that within the care sector, insurance costs have gone up significantly post-COVID, that utilities costs are going up, that food costs are going up. So we know reasonably or rationally that the costs associated with a provider supporting a resident in a residential care home have escalated, have gone up. So we need by October of this year to have completed and reported our exercise to government on what we believe is the actual cost of care for both domiciliary providers and residential care providers. And we know that that will be a challenging process. Now, I am proud of the way that Middlesbrough has worked with, for instance, our residential care providers over the last 10 years, to pluck a figure out of the air. And I think where some areas have had associations lobbying for the care sector, I think we have worked on the basis that we will try and maintain an open and transparent listening relationship with individual providers. And I think we have always sought to be reasonable and realistic about what we've paid. However, the other side of that is that it probably does cost a provider less in some respects to provide care in Middlesbrough versus the care it might take in more affluent areas in the southeast, for instance. I would suggest, and I think in the government mandating a fair cost of care exercise, and I think they are talking about absolute transparency around that exercise nationally. I think there is a concern that that may well lead to pressure to escalate in line with some other areas of the country based on the kind of the headline figures. And I advance that, hesitantly, because I don't want to ascribe avaricious motives to our care providers. That I don't think that's it at all. But I just think that this is a difficult and challenging exercise for us, and I think the cost increases when we work through it might represent a significant issue for us as a local authority, and one which we're endeavouring to build into all our planning and thinking around the refresh of the MTFP sort of as we speak. The final of the reform headings is the one which is occupying most of my time directly, and will do so for probably years to come. We will return, I think, to an inspection framework for adult social care. It used to be that there was a social work inspectorate, and local authorities had their adult social care provision inspected, much in the same way that children's services are at the moment, albeit not by Ofsted. And that would produce a verdict about how good, bad, or indifferent that directorate was, by extension, a reflection on the council. So part of the government's reform agenda was to reintroduce an assurance framework for adult social care, and they've asked the Care Quality Commission to conduct that. What the Care Quality Commission say is that they've had a strong steer from government that they should utilise familiar terminology for the public. And in short, that means that I expect that the assurance framework will utilise the inadequate, requires improvement, good and outstanding terminology that we see within the Ofsted assessments of children's services, directorates and other adult social care registered providers. We don't yet have the full framework for how these inspections, and I think we've almost pushed as adult social care directors to have them called inspections, because I think that's the way that they will be interpreted and seen. So we might as well call them that. The visits will be conducted by inspectors, so we might as well call them inspections. We know that from April of 2023, CQC will start a benchmarking process, which will be an initial look at local authorities across the region. We think it'll operate on a sort of 2-year inspection cycle. CQC, when we meet with them, have said to us that they are open, or they recognise the need to commence this process in context. And I think in context, I know what I mean, or how I would interpret the suggestion of in context. But I think what they mean is that over the last 12 years, adult social care directorates have not been inspected in the way that we're about to be. We've operated under a regime of what we call sector-led improvement, which I think in lots of respects has worked well. But I think we're coming back into inspection having had a substantial percentage of the funding that we had last time round removed from us through the austerity period. And I think that most local authorities are probably sat looking at adult social care at the minute, thinking we provide a good service to our service users, but in some respects we've probably compromised more than we would ideally have wanted to around some of the structures that we used to have around building training opportunities and some of the data provision, some of the policy officers that we used to have. And, you know, lots of those roles have been victims of the austerity period. And I also think that we're now operating a time of greater complexity and demand, but we haven't seen commensurate increases in staffing. So I think there's a challenge for me in satisfying myself that we are ready to head into that assurance process, and that will be something which occupies my mind significantly. Now, it's not about a cynical view on inspection. It's about service improvement. It's about using the framework that they produce to us quite appropriately to make sure that we have the right things in place to assure continuous improvement within adult social care, because I'm proud of the services we provide. So I think over the next few months, as the details of the assurance framework emerge, you will see first a paper for executive, which we're planning for August, and thereafter briefings to elected members to highlight the detail of the assurance framework as it starts to emerge from CQC. We are anticipating a draft of the Care Quality Commission's self-evaluation framework. We think that will probably arrive, you know, within the next few weeks. And then each local authority across the Northeast, because we've been sort of collaborating on this through Northeast ADAS, we will each conduct a self-evaluation, a draft self-evaluation over the summer. The very worst position you can find yourself in going into any form of assurance or inspection framework is to not be self-aware. So a sort of brutal and honest and open self-awareness is the place we need to get to first, and we'll work through that over the summer. And then across the Northeast, we've planned short peer reviews for all of the local authorities, adult social care directorates. So that'll be conducted by Northeast ADAS. And we've also commissioned former director to carry out some challenge sessions with us. It's an individual who is experienced in similar inspection frameworks, and they will come and grill us as directors on our data and on our performance. And then I think the key thing that we're doing, locally is I'm in discussion at the minute with Children's Services about development of some of the processes which they have put in place in terms of their service improvement. So on the back of their unfortunate judgment some years ago, they put a unit in place with a focus on service improvement, and they've developed considerable skill and specialty in working up the sort of the data systems and the assurance and audit systems that we will need to make sure that we have run through in order to make ourselves as confident as we can in the face of an inspection visit. So I'm currently awaiting a proposal from that unit at the minute for us to build or for us to invest in that unit from adult social care to build a process to systematically work us through the service improvement in advance of assurance. So I'm going to be a busy chap over the next little while, as if I wasn't already. And then almost finished, Chair, I promise. Workforce planning continues to be a challenge. I mean, obviously we had a scrutiny topic last year about recruitment and retention. We've implemented some of the recommendations from that. We're also about to take a paper to the leadership team looking at how we open up some of the progression criteria for social workers, having realised that trying to provide a satisfying long-term career for social workers is probably the key to keeping the experienced staff, which is what we absolutely need. It's becoming easier, I think, with some of the changes we've made to recruit newly qualified staff, but it's retaining those experienced workers that becomes increasingly the priority. And then finally, complexity and demand. And I've said before that it's been a cliche throughout my career as a social worker that people have said times are getting more complex, but they are. And certainly over the last year or so, you know, it's a continuous refrain that I hear from staff about increasing complexity. And I find that a compelling argument at the minute. We're seeing a significant increase in occupational therapy assessments being asked for post-COVID. We're seeing an increased complexity in the individuals being discharged from hospital. We're seeing a significant increase in domestic abuse cases. It feels like our work is becoming more complicated as we go. And we like a challenge, but you know, there are limits. So I shall stop there, Chair.
Okay, thank you. A lot of information for us to take in there. Probably too much. However, we have to come up with our plan for next year. So we're going to go ahead with that now. Thank you, Eric, for helping us with it. Hand you over to Chris for so we can discuss this. Chris?
Yes, thank you, Chair. So the purpose of the report that's been circulated with the papers is to invite the Scrutiny panel members to consider the work programme for this municipal year, 2022-23. If I take you through the report just briefly, working on the assumption that members have read over it. If we look at paragraph 2 of the report, members can see the work that was carried out last year, which include reference to a full review that was not completed and will therefore continue in September. And that refers to the role of the voluntary and community sector in supporting adult social care. So in addition to continuing with that investigation, contained within the report at paragraph 5 is a list of topical issues and suggestions which are anticipated to be of particular interest to the Scrutiny panel. And these include dementia, a 10-year plan, hospital discharge and rehabilitation from a social care perspective, arrangements for lone adults, supporting vulnerable adults, continence services and COVID-19 recovery and care provision, residential and day care. So as it's ordinarily recommended that the panel identifies 2 main topics of investigation to include in the work programme each year. Obviously, if we're progressing with the role of the VCS in supporting adult social care review, then I would suggest that we identify one other main topic, either from this list or building off the back of what Eric has presented to us there. And maybe he's build in some more updates and any other matters of interest around that. So with this in mind, I would take members to page 13 of the agenda pack and the attached aid that's shown at Appendix 1, which will help us to prioritise issues where scrutiny can make an impact, add value, or contribute to policy development. I'd also say when considering potential topics, that the Scrutiny panel is asked to ensure that topics do meet the criteria that's detailed at paragraph 12 of the report, Chair. So I would invite members to discuss and consider areas of priority, and obviously once those are agreed, I'll then compile those in a report for the Overview and Scrutiny Board and for those to be approved. Okay, thanks, Chair.
Thank you, Chris. Can we finish last year's off could we finish it off in one meeting? And then we could select 2 topics for the rest of the year.
I mean, what I was planning to say with that, Chair, is obviously we'll be picking that existing topic up from the next meeting in September. So after today, I was going to contact the panel members and maybe hold another meeting informally to discuss, potential next steps for that. We could potentially, could have it, signed, sealed, and delivered, if you like, within one meeting. I suppose it just depends on what kind of further evidence panel members think needs to come forward from that. But as I say, what I'm happy to do there is obviously we can hold a meeting informally, or I can send a communication round to all members. So obviously those members that aren't here today can also participate. Send the minutes of the meeting of the 2 previous meetings we've had. Obviously we've agreed the terms of reference for that review, and discuss potential next steps after that. But as I say, that won't be continuing now until September, which is going to be our next scheduled meeting. Obviously working on the assumption that the proposed schedule of meetings that we'll be covering later in this meeting is agreed. But by all means, if members feel that, you know, we've covered that topic sufficiently and we could tie that off in one meeting, then yes, yeah, that's a
I'll
possibility.
leave it open. Denise wants to say something. Go ahead, Denise.
Right, yeah, thanks, Chris.
Mm.
Based on what you've said there, I think if the information could be sent around to everybody, because I know, you know, at least one councillor who can't get to the meeting might be able to look at the information outside of the meeting and contribute. So I'd
Yeah.
welcome that, and then bring it back in September to see where we go from that. Do you want me to make any comments on the programme and the information that's been put forward by Eric? Can I do that now, or do you want me to wait?
Yeah, go ahead. Go ahead, Denise.
Thank you, thanks. In terms of the NHS reform and the slides that you gave us, Eric, I'm assuming that, I mean, obviously, you know, up to the chair, but I'm assuming that information is going to continue to keep coming forward to us at our meetings, so we're kept abreast of what's happening there. And then looking at your second slide, I was really interested in the charging reform, because you said that's going to have a higher demand on the service with more assessments. So in terms of a topic, I'd quite like to look at that, but you know, that's me. It's obviously up to the panel as to what they choose to look at, but I would certainly put that forward or something. Thank you.
Does anyone else want to contribute? Dorothy?
Yes, with regard really to the presentation Eric gave us with regards to costings, I agree with what Denise says about that, but I'm also concerned about the payment people have to make for the care. That really concerns me due to the climate we have at the moment, and how that's going to work, and also what we pay for that care. I'd be really interested in that, Chair. I think it's 1 and 2, 2 and 3 of Eric's slide.
Can you answer that, Eric?
I can. Like I can and I can't. What we pay to providers in order to have them provide the service for us, you know, both residential and domiciliary care, will be part of that fair cost of care exercise that we will carry out before October. As you will know from previous role, I mean, we increased the amount that we paid to domiciliary care agencies and residential care agencies. We did domiciliary care agencies first because we felt it was appropriate and necessary to raise that. So we were quite comfortable with what we were paying to domiciliary care agencies back then. But obviously the costs faced by all of us, and there's a disproportionate impact, I guess, on individuals who are on, you know, lesser incomes, it has changed since then. So it probably is appropriate that we revisit that, and the fair cost of care exercise will give us a chance to do that. The overall impact of the charging reforms obviously is the idea of the cap that people pay over their lifetime on care costs, and a change to the threshold when individuals start to pay. And obviously the increased number of assessments reflects the fact that as part of that, we need to provide the offer to people who fund their own care. And there are lots of people who fund their own care for one reason or another. We need to offer the opportunity to do an assessment for those people and start the care clock. So it's the idea that if they're funding their own care, and we've said, yeah, that's legitimate, you know, part of the assessed need, then we need to run the clock to accumulate what they're paying over time, so that when they hit the threshold for their lifetime, then the local authority will pick up that cost. And the governmental principle behind this is that, you know, they are changing the thresholds around the income we draw from individuals, but they will also change the scale of the grant that they pay to local authorities. And the initial you know, the initial assurance from government was that that would be cost neutral to us. But there are a lot of imponderables in there along the way to do with timing and whether assumptions are right or not, and quite what the impact is on both individuals and local authorities, particularly small local authorities. So there's a lot in there, and there's a lot in there for us to watch. And, you know, I probably share some of the concerns voiced by both yourself and Councillor Rooney.
Thank you, Eric.
Does that answer your question, Darcy?
Yes, thank you, Chair.
Okay. Right, let's move on to next year. I mean, I want to finish last year, which is the role of the voluntary and community sector in supporting adult social care, was a focus on 19 recovery. If the panel feels that we need more time to do this, I'm willing to take more time. I would like it to conclude in one more go, and we today decide on 2 new topics for next year. I'll leave it open to the panel to see what they want to do. Anybody have anything to say? Denise, go ahead.
Thanks, Chair. If we're looking for another topic, I mean, I think the first one around charging reform and the costs, I think that's something that we can explore. But if we're looking for a second topic, I'd like to look at hospital discharge, because we know with social care, there's been lots of issues. There's the impact of the cost of living crisis and how that's impacting on the recruitment of care workers, because they really can't afford to take jobs at minimum wage, because they can't afford to put petrol in the car and things like that. So I think I'd quite like to look at how that's stopping people coming out of hospital, and then what the knock-on effect is for that. Because I mean, if you go into the health service, then it's blocking up procedures and treatments, if you like, because you need the beds freed up in order to do that. And how big a problem that actually is, because we're hearing some anecdotal information, and I know there've been people on the radio from some of the care services and on the TV talking about the issues, but I like to explore how much of an issue that actually is for our services. Thanks.
Are you happy enough to have one more meeting on the role of a voluntary and community sector, Denise? We have to finish
In
that
terms of that, I mean, I think what we said earlier on, if Chris is going to send us out the information so that we can contribute to what's already been produced and how much we've got together, and then look and see how realistic it is to complete that quickly, because we've started on the process and I'd like to see it done properly. So if we need to do some more work on it, then I'd prefer to do that and make sure it's tied off and we get a good result on it. Thanks.
Absolutely. So we're going to do that then, Chris? No,
Yes, no problem. I'll do that.
Well, I would like to investigate the Dementia, the 10-year plan, because it's a hot topic at the moment. Does anybody
I'll go
else?
along with that one, Jim. I'll go along with that one, Jim.
Anyone else? Nobody else. Right. We have to pick 2 topics up. I'm going to pick them up today. So, Chris, how do you think we should do this?
Well, I mean, there's a few being put forward there, Chair. Obviously, so I think the panel is in agreement that we'll continue with the current investigation. Pick that up in September, see how that goes. If we need a little bit longer, then by all means we'll move into October. But we'll see how progress goes for that. After that, obviously, we've had a couple of suggestions there from councillors Rooney and Davison, but also from yourself and Jim with regards to the Dementia and the 10-year plan that's listed in the report. So obviously we've had 4 items put forward there. It's just a case of deciding which 2 you would like.
Yes.
I'll leave that up to you, Chair, the committee.
Well, I suppose the only fair way is to go by a vote, and whoever votes. I mean, I'll stand by whoever votes for whatever. So if you want to take a vote Chris on each one in turn, and the two that get the most votes will go with them.
I suppose what I would ask, Chair, for clarification is obviously with the charging reform and costs and the information that Eric provided in terms of this report that will be prepared a little later this year. Is it worth the panel receiving the information as an update rather than as a separate investigation in itself, or what would you say for that, Eric?
Sorry, run that past me again, Chris.
So you're going to prepare this report ready for, did you say October time? Was it for the autumn?
In terms of
Charging reforms.
in terms of charging reforms.
Mm.
The report that I said I anticipated bringing was about the CQC assurance regime, which I anticipate taking to executive in August or thereabouts, and then briefing to members after that, depending on when the information actually emerges. The fair cost of care exercise needs to be completed and reported by October.
Yeah.
So I think those were the two dates that I was thinking about.
Yeah. Okay.
Can I throw something else into the mix, please, Chair? And it's not it's not a topic as such, but I am thinking that I've made a couple of comments there about increases in demand, and I just wonder whether or not there might be a role for me to bring some of the performance activity information to scrutiny on a sort of regular basis for the panel to cite it, just so that you're seeing some of the kind of the live changes in the volumes that we're dealing with and some of the challenges we deal with that way. I just wonder whether or not I might bring rather than me giving a verbal update on something, whether or not there might be something more in the realms of performance data that you might choose to look at. That might be something that Chris and I come up with some sort of proposal outside of this and then bring back, Chair.
Yeah, obviously, we want to help you along as well, Eric. Have you had a big influx of care since COVID COVID's not over, but it's eased off? Have you had a big influx of people going into social care?
More in some areas of activity than in others. Like I say, we've seen increases in domestic abuse. We've seen increases in complexity around hospital discharge. I mean, we're still really in a sort of recovery phase from COVID. Our mental health teams are very busy, and I expect will remain busy for the foreseeable future. And some of that, it's difficult to draw with assurance the direct connection to the impact of COVID or the impact of the lockdowns, but we're certainly seeing the activity data. I just feel that there may be merit in the panel being cited on some of the volumes that we're dealing with and some of the trends in data, because that might, a year from now, if we were, for instance, to bring a short performance report every quarter, a year from now, you would find it quite easy to look at some of the topic areas where we're seeing changes in the profile, and that might help you in future to link your deliberations on further scrutiny topics directly to the data that we are seeing. That might be a useful way to work.
Good topic, Chris.
Topical performance report / update. I think I'm just thinking about the suggestions that have been made. Obviously, we're going to tie off the current investigation. The Dementia and the 10-year plan that yourself and Councillor Wilson are interested in, that could be an option. I think Councillor Rooney's suggestion of hospital discharge is a good one. Whether or not you want to link that in with, what I looked at in the report itself, which was looking at lone adults, that could potentially feed into that if you want to bring that in as well. But that could work for you. I think the information that Eric's given regarding the charging reform and costs, and also around performance activities, I think those would come as useful updates for the work programme, rather than actual investigations, because obviously it's ongoing. And like Eric says, I think that would help us in subsequent years as well, when we get to this stage. I mean, with that, we could throw an update in there with regards to the social work recruitment review that we done last year to find out how that's been going. So there is a lot. There are a few options that we could put together.
Sorry, can I put in, how has it been going, Eric, the recruitment?
Thanks, Chair. I think we've seen some changes with our social care workers, who are some of the staff members within the Directorate, who are, I'm always careful about how I say this, they're not qualified as social workers, but they have a whole range of other qualifications and skills and whatnot. Some of those individuals went through the job evaluation process, which I welcomed, and we've seen some changes to the salary structure around those individuals, and that's helped us around recruitment. I think we have found that things have become easier, a bit easier, around recruitment of junior social workers, so the newly qualified workers. The bit that we're now, so we're short of 11 social workers, I think, today, which is still a substantial number, but better than where we were previously. And the challenge for us now is about retaining experienced social workers, because that's a really important dimension for us. So I think it's eased a bit, but we're still finding that when we advertise posts, you're often getting no applicants or single applicants. And that's something I was talking with the directors of adult social services from the LRT authorities today, and it's continues to be reflected across our neighbouring authorities and right across the northeast. I mean, Redcar are in the same position we are in terms of recruitment retention at the minute. If I may, just while I'm speaking, Chair, the Dementia 10-year plan that Sajid Javid announced, by way of a topic, I mean, you'd probably want to frame that somewhat differently. I mean, they've announced a 10-year plan. We're right at the very beginning of that. So at the moment, that's only really going to be an information update about the intentions stated within the plan. I think there may be other things that we would choose to do around looking at dementia, but the plan itself is simply going to be a plan at the minute rather than anything tangible.
Okay, well, we'll scroll it on out then, Chris. So
Yes,
what was
Chair.
that, Chris? The hospital discharge? And one more.
Can I just jump in there,
What was
please?
the other one you said, Denise?
I was talking about and so was Dorothy, talking about the charging, which Eric has now agreed to provide updates on as that works through. So I'm happy with that. I'm happy as long as the information's coming forward, so we can have an opportunity to comment and feed back into it. I'm more than happy with that. I think the hospital discharge as a topic is one that would fall neatly into scrutiny, because there's quite a lot of information out there, and it's an established process, so we can have a look to see what's going wrong. I mean, my feeling would be to leave it at that and let us keep the other list as it is and visit it once we're coming to the end of the voluntary and community sector, because there is, there's a chance that through the reform that something else might just come up that is more urgent that we would want to address, and it gives us that flexibility. So that's my suggestion.
Can we change midstream if something comes up?
Can, Chair. Yeah, we are pretty flexible in that regard. We did last year with the recruitment and retention of the adult social care workers. That was added in later on in the year, of course, after the year programme had been agreed, and that was fine. It didn't cause us any issues. So I would suggest that we where possible, we do retain as much, you know, flexibility as we can, really.
Sorry, Graham, you got your hands up there.
Yeah, just popping with Denise on that one. Hospital discharge and rehabilitation. Can we squeeze GP service?
It's frozen. Kind of suggested that might come under health, the GP surgeries, and they're already looking at it. It went to the health scrutiny yesterday.
Okay, let's move on. Chris, I think we're nearly there. So we're going to finish the funded sector one from last year.
Mhm.
And that might take 1 month, it might take 2 months. And then we'll go on to the hospital discharge. And we'll see how that far that goes after that.
Okay.
Is
Yep.
everybody happy with that? Yeah, thank you, Dorothy. Okay, and thank you, Eric, as usual.
My pleasure, Chair. And with your permission, if that's okay, I'll drop out now.
Yes, thanks a lot.
Thank you, Chair. Thank you all.
Yeah.
Bye-bye.
Okay, Chris, we're clear on that? Yeah.
Yes, Chair, that's fine. Thanks.
Right, we'll move on to item number 7, which is the OSB updates. And there's been 3 meetings actually since we met last. The first meeting was on the 27th of April, and we spoke about the Executive Forward Work Programme, school exclusions discussion with secondary schools, Chief Executive's update, and the Scrutiny Chair's update. On the 11th of May, we had the Executive Forward Work Programme, Executive Member Update, the Chief Executive's Update, School Exclusions Feedback from School Visits, the Children and Young People's Social Care Scrutiny Panel Final Report, Sufficiently and Permanency, and the Children and Young People's Social Care Scrutiny Panel Final Report, locally working from a children's services perspective. On today's meeting this morning, we had the Executive Forward Work Programme, the Chief Executive's Update, the Communities and Culture Scrutiny Panel Final Report, School Exclusions Feedback, the Strategic Plan 2021 to 2024, and the Revenue and Capital Budget Year-End Outturn Position 2021-22, and finally, Scrutiny Chair's Updates. And that's it. Anyone, anything else to say before we close the meeting? No, I don't see any hands, so I thank you all for your attendance and once again for all your input. And
Chair?
we'll see you. Sorry, Chris.
Chair, sorry to interject, just the proposed meeting schedule for the remainder of the year.
Yes, sorry.
Agenda item 8.
Right. Item 8. The proposed meetings. You've sent out the schedule, Chris.
I have,
Everybody's
yes.
got it? And can
Yeah.
we agree? Can we agree on it?
In the main, it's just obviously time and dates at the moment. Venues is
dates,
to be confirmed because there are some
Yeah.
discussions taking place around whether meetings will be physical or virtual. So depending how discussions.
That's our last item. I want to ask the panel whether they would like to meet virtual or in person. And so this is not a vote, by the way. It's just want to know your opinion. So can we have, we just go around, Dorothy, you're first on the list there.
Yes, I think I gave my opinion this morning, Chair, is that I would really prefer virtual.
Denise?
I'm happy either way. I really am. I like coming in to see people, but this is convenient.
Yeah, Ray?
Yeah, either way now.
Either way. Geraldine? You're Miss Geraldine? I think it's a virtual. Yes, right. I'm a lip reader. Graham, I don't know where Graham's gone. Gone off. Anyway, it's not a vote. It was just an opinion because it's going to full council in July, and we'll probably have to have a vote on it after that. So, thank you very much again for your attendance. Thank you very much for your input, and we'll see you in September.